Good evening, and welcome to the Howard Studio Theater of the State College of Florida, Manatee, Sarasota, for our first community conversation of 2017. I'd like to thank our forum partner, the Bradenton Herald, and our broadcast partner, Manatee Educational Television. I'm Brian Thomas, one of your co-hosts for tonight's event, and clearly, I'm not Dr. Carol Probstfield, your advertised host. Dr. Probstfield is under the weather tonight, but sends her thanks to both our panel and our audience for giving consideration to such an important topic. For several years now, Manatee County has had the dreadful reputation as ground zero for heroin and other opioid overdose deaths, with more per capita than any other county in Florida. Law enforcement agencies continue to state that society cannot arrest and incarcerate its way out of this devastating tragedy. The best solution lies in efforts at prevention, education, and treatment, and that's what we'll discuss tonight. College campuses have traditionally been places for healthy, lively discourse on timely topics, and we welcome that conversation this evening. I think we have an interesting topic for tonight, and thank you for attending.
Thank you, Brian. I'm Chris Willey, the editorial page editor of the Bradenton Herald, and let me introduce our panel. Our guests are Representative Jim Boyd, R. Bradenton, who has been a leader on legislation to combat the crisis and is working on a comprehensive bill to, I believe, on treatment and prevention. Dr. Jessica Spencer is a Florida Certified Prevention and Addictions Professional. Mr. John Bowman is founder and CEO of SureMed Compliance, which he helped create to end the drug overdose epidemic. Thank you for your time tonight. Now our first question. You each come at this from a different perspective. Could you summarize your approach to fighting this societal scourge? Representative Boyd, we'll start with you.
Thanks, Chris, and Brian, thank you and the college for having us, and these forums are always very useful and very productive, and the community likes to be here and appreciates what you do and allowing it to happen, so thank you for having us. This issue has been, I've been in the legislature 6 years now, and in one way or another, this has been a problem, a big problem that's gotten bigger and bigger since I arrived in Tallahassee. And you know, years ago, right after we first were elected, the pill mills were the big problem, and they were a huge problem. And I believe that we did some good in some legislation that eliminated and cut back on some of it. I'm not saying that problem has gone away, but there was a lot of work that was done to try to get at that problem. And a lot of that was on the East Coast, but we had plenty in our communities as well. So we kind of push that back a ways. Other things pop up. You know, it's a kind of a bad analogy, but it's almost like whack-a-mole. Mm-hmm. You know, you bat one down and something else pops up. The heroin epidemic that's grown over the past several years, and I'd be willing to bet that probably there's not a person in this room, including myself and others probably on the panel, that through family or friends haven't dealt with this crisis in some way. And it is a crisis. You know, Manatee County unfortunately has the reputation now and of one of the leading areas in the state. We've got to do something about it, but it's just such an insidious problem with so many different aspects that it's hard to fix entirely. But we're going to do our best, and I'll be brief in a little bit of a description here and let the other folks talk. But we can go through the details of what this means to our community in a variety of ways, from healthcare to treatment centers and the like. But one of the things that I'm working on this year in collaboration with the Sheriff's Association, the Attorney General's Office, and then as well the statewide prosecutor for some of the drug crimes is the bill that you had mentioned, Chris, and that's essentially ours is increased penalty phases and also scheduling some of the derivatives like the carfentanil and the fentanyl, which has become a big problem for scheduling them as substance ones on the schedule. So that would increase penalties and make it felonies for those that use those. And I want to talk a little bit more about where this problem's coming from and how it's getting here and how we're dealing with it in the state. But I'll stop there and let the other panelists kind of weigh in, and then hopefully we'll have a chance to develop the conversation a little bit more along the way.
Absolutely. Dr. Spencer, please.
So many know my background is substance abuse, addiction. I've worked in treatment for the last 20 years. I've been pretty much everywhere within the jail systems, within the treatment systems, school systems, school settings, regular school, alternative schools, all of those places in the community. For tonight's purpose, I really want to focus on the prevention end of it, which is what we had talked about, because really that's where my heart is. I do believe that there is a place for treatment in treatment centers. I think they are woefully underfunded. I also think that they are not treating these people that need help in the way that they should. So I do also come from the health and wellness and really a different approach to treatment. But for tonight, I'm really interested in prevention. My heart is in prevention. Prevention starts very young, and that's where I see the most change happen. And so that's what I'm really excited to talk about tonight, is some ways that we can prevent these things of getting to where we have to have new legislation to increase treatment, et cetera, et cetera. So I'm excited to talk about prevention.
Great. John.
Yeah, my name is John, and I started a company called SureMed Compliance. We actually started a company. I started a company with a partner of mine in an attempt to help this community. When you see statistics like 9 people a day overdosing in Manatee County of either prescription drugs or heroin, you start to take note, especially when you see friends that you went to high school with and family members struggling with it. One of the things, I come from a pharmaceutical background. I did marketing and sales in pharmaceuticals, and so that is kind of where my input into the company came from. My partner is in law enforcement. I'm not going to mention his name right now, but he is one of the people that actually picking up the bodies and administering Narcan. So together we put our brains together, and we worked with a handful of physicians in this town, as well as attorneys, as well as just about every walk of life that has any stakeholder that has anything to do with this epidemic. And we said, something's different about this. It smells different. It looks different. Why are we treating it the same? I propose a question even to everybody in the audience here, but if you know what, I use this example quite a bit, but if you know what SIDS is, sudden infant death syndrome, by classification, after about a year old, it doesn't even classify as SIDS anymore. If we saw a bunch of 2, 3, 4-year-old kids dying from SIDS, we wouldn't continue to treat SIDS the same way. And yet that's exactly what's happened with this heroin and prescription drug overdose epidemic. These people are coming from a completely different demographic, and it's affecting now very, very, very well skilled. It used to be that it was in a group with a certain number of risk factors that were there. The risk factors now, the people who are addicted look like me. They wear a blazer, they go to work every day. They have very good professional jobs, they have kids, they hide it well. They hide it for many, many, many years sometimes, and they control it as long as they can. And then one day they die, and it's a huge surprise to people. And so the main goal of SureMed Compliance is to say we can keep chasing our tail, and we can keep trying to help people and giving them methadone and all that, and that's great. I think there's some, well, I won't say it's great. I think there's some good things about, some good ways to treat it when it comes to addiction, but I think we need to break the cycle somehow, and that means there has to be less people becoming addicted to these drugs. And we know that the pathway to heroin, when the New England Journal of Medicine releases a study in January of 2016 that says that over 80% of all heroin users were started by an opioid in an office by a doctor, then it's very, very clear where we need to pay most of our attention to. It's right there at the doctor's office. And yet that tends to be the place that we all just go, well, that's doctors, let them do what they do. And I can discuss a little bit later on about what some of those those factors are that are involved in that. But there's economic factors. There's a lot of different reasons why physicians don't even have the time to invest in figuring out whether a patient has the underlying disease of addiction before they ever write them for a prescription. So.
Okay, thanks, John. Joshua Barnett, the manager of healthcare services for Manatee County, presented information 2 weeks ago on overdose statistics and Narcan administration to the Manatee County Commissioners, and suggested looking to prevention rather than reaction. He summed it up with, an epidemic is not typically treated through a medication. There isn't a take this pill solution to this. When you address an epidemic, you're addressing it from a multifactorial, multifaceted way of impact. And he said opioid addiction should be treated the same way. So this question is for the entire panel, but we'll start with you, Representative Boyd. How can the state, the county, and the community address this issue?
Boy, that's an easy question to answer, Brian. Thanks for throwing
No
me out
problem.
first.
We'll be done here in a moment.
It takes everybody, and I think Dr. Spencer was alluding to that a few months ago. It's not just law enforcement and taking care of it from a penalty phase. It's treatment, it's education, it's a variety of things, and as John said, it's touched every segment of our society, from, unfortunately, from the homeless people that live on the street to the professionals in offices downtown. So there's so many components that we've got to get at. The bill that I'm working on is kind of a single-pronged issue. There's another bill that I believe Representative Gruters from our district, from our community is promoting, and that's for a pilot treatment program for Manatee County. I think there's a $500,000 or so appropriation for that to do in the form of treatment, work. We've got to look, and I'm not in law enforcement, and I will tell you, the sheriff and his team have done yeoman's work on the law enforcement end, but we can't just keep arresting people and putting them in jail and hoping they're going to, change their habits. They're not. There's got to be treatment. There's got to be education. There's got to be counseling. And I know there's a lot of people, and Dr. Spencer's one of them, that's been working very hard on that. So hopefully she can tell us a little bit more about the education component. But there's just so many different facets that we've got to all kind of work together to get our arms around, and hopefully in a concerted effort and a kind of a consolidated approach, we can make a dent. I would like to sit here and tell you I think we can solve this problem entirely, and unfortunately, human beings are human beings, and they do things that sometimes aren't in their best interest. But I know we can get at the problem and start to work on some solutions that'll be productive for our community.
Am I up next?
Sure.
I think, yeah, we can get at it for sure. And arresting our way and even looking at it from a law enforcement perspective and a treatment perspective is not the only way to do it. So I actually like that question and that statement because it is multifaceted. And of course, from my perspective and from what I see, and for my work is for the long-term gain. It's not for the immediate gain to see, well, what kind of impact can we make in 6 months or a year? The impacts that are made from prevention when we start educating our youth from really, really small, you're gonna see those 10, 15, 20 years down the road. Unfortunately, what I find is people want that quick fix. We wanna know, how can we fix this in our community immediately? Well, we can't. We're not going to. And that's an unpopular statement sometimes because people want to hear, oh, it's gonna be rosy in a year. Well, it's not. We all have to come together and do the multifaceted approach, but we really need to enforce our efforts and put our efforts into our children. We need to take our children back. We need to take our school systems back, and we need to make sure that we're educating our youth from the time that they're little bitty babies, that we don't take a baby aspirin when we have a headache. We drink a glass of water. We let them fall down. We let them fail. Instead of giving everyone a trophy, they need to understand from that small that it's okay to fail because those are where the biggest lessons are. And that's where the greatest achievements are found. But we're not seeing that these days. So I have sometimes a very unpopular approach, but it's very practical and reasonable and it's worked. But we need to take our children and our communities back, and we need to all do it together. And it will take legislation, even within the treatment community. But for me, it's about reaching those little guys, teaching them really good self-esteem, healthy habits, and understanding so that they don't reach for the pill bottle, they don't reach for the alcohol, they don't reach for the vape pens and the e-cigs and the marijuana, and that we raise healthy children. That way we can help in the community to make sure that they go forward positively and become and be and stay productive members of our society.
Yeah, I would agree with that. From a cultural standpoint completely, I see you kind of handling it from when they're children all the way up. I would say our approach to this would be a little bit more of a how do we start to fix it right away? And I agree. I think if we raise better kids, that's going to have a big impact on it down the road. I don't know if you guys have ever heard of a company called Purdue Pharma. Just by show of hands, anybody heard of Purdue Pharma? Purdue Pharma was responsible for manufacturing and marketing a drug called OxyContin in the 90s. What they did is they took a molecule which is about 2 nitrogen chains away from being heroin, and they marketed it as a pain reliever and told people that it's not addictive. And they used studies to try and show that as well. And so there's a big lawsuit where they settled, and they paid a huge sum of money, but they made billions and billions of dollars on OxyContin. Another thing that they did is they were able to lobby Congress and some of these other, as well as some of these other medical associations like the AMA, into treating pain as the fifth vital symptom or vital sign. So when you go in to get your blood pressure done and all these other things, the next question you were supposed to be asked was, do you have any pain? Well, 50% of Americans complain of chronic pain. So what happened is doctors, what they also were told is that if you don't treat pain, you're going to get in trouble for it. Reduced reimbursement for Medicare was one of the things that doctors got in the 90s. It still happens right now in nursing homes, actually. And doctors can get in trouble if they don't treat pain in nursing homes. And so we have put ourselves in this situation by allowing a company like Purdue to do what it did. I don't think a lot of people don't realize the history of this, but doctors were told for 10 years, you better treat pain and you better treat it well. And so I'll ask you guys, I'll just address the audience on this one. If you go in to see your IRS lady or your IRS guy and you're doing your taxes, and the IRS person's telling you, no, you can write this off, write that off, and do this, you probably listen to them, right? You probably wouldn't go, no, I don't know about that. It's the same exact thing with physicians. You walk into a doctor's office expecting that they're going to tell you what's best for you. So when a doctor gives you a very powerful drug, 2 nitrogen chains away from being heroin, and tells you this is going to help your pain, without doing a full workup to find out whether or not you have the underlying disease of addiction, without finding out whether you have any of these predispositions or these genetic things that are there, you're going to take the medicine. And here's a really alarming statistic. If we know that patients that take, and this is right from Washington State, from a study that was done through their work comp, if a patient stays on an opioid for more than 90 days, that's 3 months, there is a 60% greater likelihood they will still be on it at 5 years. Now think of that for a second. You fell off of a ladder, you hurt your elbow, you have acute pain, which should heal in 2 to 3, 4 days. A doctor writes you 30 Percocets. By the end of that month, you need that medicine. You've actually developed a tolerance to it because your mu receptors, which is what the opioid binds to, has upregulated, which means all these activated receptors that weren't there before are now asking for that drug. So the doctor says, how is the medicine working? And you say, it's working great. And you're realizing it's helping you cope, maybe, and you're realizing it's helping you relax at night, or maybe it's helping you with whatever else is going on in your life. Now, for people who don't have addiction issues, this really isn't an issue for most people. But when you've got a lot of people with addiction issues where that hasn't been defined at all, they go right back in and they say, yes, it's working great. And by 90 days, that patient has got a lifetime sentence to taking an opioid. And then what happens when the doctor all of a sudden, and now all of a sudden in 2012, there's enough case law to support a felony conviction of a doctor if a patient dies of a drug overdose. I want you to think of how the tables have turned. And think about how confusing that is for a physician who has to see patients now who was just told that if you don't do this, you're going to get in trouble. And now he's being told, take these patients off opioids who have been on for 10 years. Where do they go? Or they're lowering the dose because the CDC said that a 50 morphine equivalence is the most you can give for a primary care doctor. And they've been giving patients 120 morphine equivalent doses, 500 morphine equivalent doses. And doctors are instantly in 3 months cutting their dose. So what do you do? I mean, we look at it and we say as a company, our company, what we do is we go in the doctor's offices and we educate these physicians on what is proper prescribing, what's responsible look like, and then we audit their charts. And it's all internal. They don't have, only in one state is it mandatory. In Alabama, it's mandatory, but in Florida, it's not mandatory yet. But that's how you change the epidemic. That's how you address it. If we know that 80% of patients or 80% of heroin users have taken opioids first, it seems pretty simple. We have to get doctors to stop writing opioids for chronic pain. Did you know there's no evidence whatsoever that chronic pain is effective in the management of chronic pain? Chronic opioid therapy, I'm going to say that again, there's 0 studies to suggest that chronic opioid therapy is effective in managing chronic pain. 0. Because we know what the receptor site does. It upregulates, and by the time you get to 500 morphine, there are people that are taking literally 500 milligrams of oxycodone a day, and they're walking around normal. So.
I think there's another piece to that too with the fear for doctors is how many need their health insurance to go see their doctor? Pretty much everybody, right? Because I know I cannot afford to spend $125 on a doctor visit, let alone $250. I need my copay, right? 15, 20, whatever. Doctors are also rated by their insurance panels. So now if we are required to write a prescription to treat pain, again, that 5th vital sign, and we don't, and the survey comes out and you're mad as a patient and you mark me or your physician as a 0 or a 1 or a 2, they'll be dropped from that insurance panel. So they've got a lot of things held over their head that, again, you're in a great word, confusing. It's very confusing for these physicians, and there's not enough resources. But that is another fear base too, is they will lose their insurance panels because they are not being rated properly or rated high enough on those insurance panels. And who will be able to afford to come see them? Not many people.
And if I could just add one thing, complicate that with the problem. And this is legal. This is doctors that are looking out for their patients and trying to do the right thing. But then take the flood of these drugs and these the fentanyls and the carfentanyls and the things that are coming in from China. And John mentioned the molecule change. In Florida, the 6 years I've been in the legislature, every year we've got a new drug bill to fix a problem that was created by a drug that in lots of cases now we're finding came from China and it wasn't illegal here, but it was a very strong, powerful drug. And some of these, and you know the stories, but some of these you take one time, and you're either addicted or worse, it kills you. I mean, the thousands and thousands of times more powerful than just straight heroin. So we're trying to get at, in the legislation that we're working on this year, that as well, so we can intercept these derivatives, from a legal standpoint, from a prosecution point of view, before as they get here, and then we don't have to kind of wait till the legislature gets back every year to fix the problem that happened last year. I was reading an article the other day that China finally has decided that the fentanyl is, possibly even a homeland for them, a homeland security issue, and they've banned fentanyl, which the U.S. Drug Enforcement Administration says could be a game changer for us. We'll see. I imagine there'll be lots of other things that'll come up that we'll have to deal with, but finally, I think some of the law enforcement here in our community is telling me that's where a lot of the drugs are coming from, and and in some cases you can get them FedEx to your doorstep. So that's the, if you will, kind of the dark side of the problem versus the side where doctors are actually trying to treat their patients in a responsible way. So it's too available, first of all, and it's too easy to change. Scientists in some of these countries are taking old drug patents that we had in America, and tweaking them a little bit and changing the molecular structure of the drug, and it's not illegal yet, and they're shipping them over here. So that's some of what we're trying to get at from a prosecution point of view and from a management of this flow point of view. But that's just one component.
I'm going to start with you, Dr. Spencer. If society could eliminate heroin, fentanyl, and other deadly mixtures that dealers are peddling to perhaps unsuspecting drug addicts, what do you think would happen?
I think that's a little bit of an unfair question, only because it's never going to happen. So that's a fantasy land. We're not going to get rid of drugs. Drugs have been here for thousands of years, hundreds of years. Heroin's been here forever. That's not really the issue. Certainly the issue is reducing the amount of drugs, and again, I think Representative Boyd, made a very good point that our law enforcement has done an excellent job with that. Our code enforcement did a great job even with the pill mills. So it's a little unfair because we'll never get rid of drugs. But again, it goes back to how do we reduce them, and maybe it is through legislation, to help our enforcement agencies. And then, what do we do from a community? We need to, again, I'm going to say it, we need to take our communities back. We need to use our voices. My question, you often get, well, what are you doing to fix the problem? Well, I want to know what you're doing to fix the problem. What are we all doing to fix the problem? Are we using our voices? Are we talking to one another? Are we creating safe places for our kids? Are we creating safe places for our people that are addicted so that they don't feel like they can't come and talk to somebody, or they can't come and get help, or they're stigmatized for it? It's awful. We need to be working together. And again, my question is, what can we do together? And if it is reducing the drugs, great, but we're never going to eliminate them, Chris. We know that. It's just an impossibility.
Anybody else want to address that?
I would say, I love that you think that way, that there is that perhaps utopia out there, but I think Jessica's right. This is, I think back 10 years ago or so, I was listening to Bobby Bowden, Coach Bowden speak, and somebody from the audience asked, Coach, your 50 years or so of coaching, kids have changed, haven't they? And he said, kids haven't changed, families have changed. And that's exactly, I think, the point you were making earlier, Dr. Spencer. We have got to start talking about these things at the kitchen table. We've got to have dinners together. And I know I sound like an old guy now, but I mean, we've got to be able to communicate with our families and our friends on a level that they get it, because they're going to go to school, they're going to go to the, park, wherever, and drugs they're everywhere. I mean, it's not like they're going to have trouble finding them. And so the reality is we're probably, unfortunately, never going to get rid of drugs in our community, but we've got to start teaching each other that these are the consequences, and this is what happens and what it means. But to your point, crime goes down, workers are healthier, they're able to be more productive, families are more productive. I mean, drugs are such a bad problem for all of us, and what they do to those that are taking them and what they do to those around them, that life would be, we'd still be, human, of course, but there would just be so many fewer things that are impacted if we could just whack this problem back. And it is a perfect world that probably we'll never get to, but it's something we've got to work hard to try to strive for.
I have a follow-up question for you, Dr. Spencer. You had mentioned that what is essential is getting to the youngest children. Mm-hmm. Isn't that a parenting issue? And how do you get parents to own up to that if they're using or...
That's where it's a very unpopular answer, because often people are like, oh, well, you're attacking the parents, you're attacking the school system. No, I'm not. I'm just telling the truth. And it doesn't mean that you're a bad parent, and it doesn't mean that you're a bad educator, but you actually may not even realize that you brought up the #1 deterrent for drug use, family dinners. It's proven. It's the #1 deterrent. So it goes back to the dinner table. But again, families have changed. We're in a different society. We have 2 parents that are working. It's hard to be a parent. It's hard to be a parent just with everything that we see. But we've got to figure out how we can do it for our families. And maybe it is you don't have dinner 5 nights a week together, but you have it once. Maybe it's every night you make sure that you go into your child's bedroom and ask them how their day went. What's the greatest thing that happened to you today? What's the worst thing that happened today? And let's talk about it. It's all about that communication and that discussion within the family that we have gotten away from. And, it's not up to the school system either. There's a lot of thoughts that, the school system, they should be educating our children. Well, the problem with our school systems right now is they're teaching to test. They are not teaching to connect. And that's unfortunate. But that's also not entirely the school system's fault either. But we need to all work together to come up with ideas of how do we bring it back to the family that, like you said, have changed. We just need to think outside the box.
Good. Right.
Well, and
Can
go
I
ahead,
just?
John.
I just want to say I agree with the cultural. Again, I think we're bringing it right back to the cultural piece of this, which is there's the decimation of the family, which I 100% agree is the root cause of a lot of issues in society. I would say, though, that if we're looking specifically at the heroin issue and about this, why Manatee County, for instance? Are families worse in Manatee County than they are in Tallahassee? Are they worse in Manatee County than they are in Idaho? We're looking at it from the same way we've always looked at it, I feel like, which is these things have now eroded to the point where everybody's hooked on heroin, which I don't believe is the case. I don't think the lack of family dinners is why people who were once very had good jobs are addicted to heroin and are on the streets now trying to get fentanyl. What's that? So again, I think those all contribute. We look at the multifaceted approach to it, and I agree. That is a huge thing that I'm passionate about anyway. Just as somebody that kind of pines for the old days of family sitting around the table, we do it in our family, but. The bigger issue is that addiction is real and it's a disease, and there's genetic components to this. And if you give somebody who has the underlying disease of addiction a 30-day supply of Percocet, they're going to be a mess after 30 days. And if you give them another 30 days after that, they're going to be a bigger mess. And then when you cut them off after that, they're going to go on the street and get something to try and feed the need, because there is now a biological process that's gone on in their body and they can't stop. And this isn't a moral failing. We're treating it almost as if morality it's a lack of morality that's making people go try a drug like carfentanil, which is 100 times stronger than fentanyl, which tranquilizes elephants. And again, I'll say this, an 18-year-old kid who's never tried drugs before doesn't go out in the street and say, let's go shoot heroin. It doesn't start there. They don't do that. But what happens is they get their wisdom teeth out And then somebody writes them for a 30-day supply of Percocet, 10 milligrams, and after 30 days they realize, I really like this. And there's biological processes. So again, I think at the end of the day, yes, we'll always have drug addiction in our society. It'll never go away. I don't agree that I don't think it's ever going to go away. But why is it escaping the traditional demographic? Why is it now ravaging our country and ravaging our state and ravaging this county? And I don't think it has to do with the lack of family dinners. I think that plays a part in what will always be why there's drug abuse. But there is a big demographic that we're missing here. And these are the people that normally would not be doing drugs that are addicted, heavily addicted, and are going to die. 9 today in this county.
Well, one of the, the heroin is cheaper than most any other drug now too. You can get a heroin for 10 or $15. So and listen, I completely agree that family dinners aren't going to solve the problem. But with kids, with younger folks as they're coming up, I think those conversations need to be had. But the professional person that went from the pain medicine because they hurt their back to trying to find something else. I mean, that's another issue that we got to get at. But and your question was, why Manatee County? And I've asked that question over and over. I've asked it of law enforcement. I've asked it of counselors, and there is just no good reason that we've had it here in such an epidemic proportion. But it's here, so we've got to figure out what we're going to do about it.
Well, and then we also have the question, why is that the only one that we're talking about? Manatee County also leads the state in another drug for deaths. Does anyone know what it is? I know a few of you might, but don't say it. Does anyone know what the other drug we lead the state in?
Oh, man.
Cocaine. But we're not talking about that. So why aren't we having these conversations about everything that we need to be talking about? And to the whole point, this is not about a sniper fixing a problem. This is about a shotgun blast. We need it from all facets. We need it from the physicians, which, even locally, that's what they've been working on with LECOM right here, and even State College of Florida, we need to be working to educate. This is not a singular myopic issue or problem. We have got to be working together on all of these different pieces. And sometimes certain individuals and certain groups and certain agencies get caught up in, this is the only way to do it. I am trying to stay in my lane tonight and only talk about prevention, but that's not going to fix the problem. So we all need to be coming together, opening up our eyes to not just what we're interested in, but these other pieces that will help and solve the problem.
Okay. We've talked about families, and we've all seen the photos. They're the ones that ends up in the media. It's the small child in the car seat in the back of that car. It's the kids that get taken out of an apartment somewhere because their parents are addicts. What can be done, and what can we do to assist those small children in not going down the same path? John, do you want to start us off there?
Yeah, I mean, I can just summarize it as best as I can. Again, and let me just say this, Representative Boyd, I 100% agree with your take on family dinners, and that I didn't want you to feel like I was saying anything negative about that.
Not at all.
I agree the cultural components of that are very, very important. So, I would say that kids are as more of this genetic mapping goes on, and we start to realize that genetics plays a huge role in kind of what our behaviors are. We start to see that kids are born with predispositions for this. Now, again, everything operates on a threshold, if you will, or on a spectrum, if you will. And when you get to a certain part, we go, okay, you have the disease of addiction, right? When you get too far over here. But people have the underlying disease of addiction. This is, the medical community has come out and expressed this. It's the way that it's being talked about, and it's the way that I completely agree with it. I think, how do you get kids to not follow in their parents' footsteps? I think let's find out if there's a genetic, we know there's a genetic component, so we know that if parents are addicted, there's a likelihood that the kids are going to become addicts as well already. So I think assessments to figure that out at an early age. And I think assessments at an early age before they're hooked. You can give an addiction assessment to somebody who's addicted to drugs, and they'll pass it with flying colors. They know exactly what answers to. It's not a lie detector test. But if you give assessments to kids when they're younger to find out about addiction, you can start to figure out whether or not this person's going to have an issue with this later on in life. And then we have to be really, really intentional about how we treat that patient, especially when they're in the hospital, and how we treat that patient when they're in the doctor. We talk about risk and benefit as far as physicians are concerned when they treat patients. If a patient has the underlying disease of addiction, that patient should never get an opioid, ever, unless it's acute, unless they have a compound fracture and they're in the hospital. They have to get morphine. But there should never be that for patients with the underlying disease of addiction. So how do you do it? I think assessments are really important. Getting people to take them at a younger age so that we know exactly what, and actually getting some people, as these tests become more sophisticated, making sure that people, can get genetic testing done at an affordable cost so that they can go, hey, by the way, we know it affects it. It's a big enough issue where most people that can afford to get a genetic test should have some kind of testing done at a decent age to find out whether or not they have the underlying disease.
Thank you. Anyone else?
Well, this is not real popular in the medical community, and I'm certainly not a physician, but I've had conversations with our friends at Florida Medical Association about, you mentioned earlier, John, I think about the 30-day prescription of Percocet. I mean, is that necessary? Could we prescribe, if you had a back surgery or whatever, could we prescribe a week of therapy and then reevaluate at the end of the week? But that's complicated because it would take another office visit, it might be another copay, it might be, that insurance covers it, that insurance doesn't cover it. I mean, so I know there's a lot of moving parts there, but oftentimes you hear of these people, and good people like us, that that get a prescription for good reason and for correct purposes, but it maybe shorten that window a little bit where you can have to reevaluate the patient and make sure that they still need it even.
I got to agree. You hit the nail on the head. This is one of the driving factors that is going to continue to keep the cycle of drug abuse going, is the fact that physicians have about 5 to 10 minutes to see patients now. So if last time you've seen your physician, if you go back not even 20, 30 years ago, doctors would even do house calls. And you'd have sometimes 15, 30, 45-minute office visits where doctors could do full workups. There's a reason why doctors only do 5 to 10-minute workups now. It's because Medicare reimbursement and Medicaid reimbursement has reduced so much that physicians can barely keep their doors open. If you want to know why medical groups continue to grow, it's because some physicians pay more pay 50% of their salary goes to insurance, so they can have liability insurance. So there's an economic part of this as well, where we have to allow doctors to make a decent living so they can spend some kind of time. If reimbursement went up and a doctor was able to now spend 30 minutes with a patient, they would be able to do the assessments. We walk into offices all over the country right now, and we go into physicians and we say, here's the things that you need to be doing before you ever write a prescription for an opioid. And they look at us like, you're crazy. I'll go out of business if I do that. I've just tripled the time that I have to spend with that patient. And I go, well, you have to do that, or you're going to go to jail when somebody dies. And they're like, we'll have to roll the dice. That's their mindset, and they're right. They're not wrong for thinking that way. They have to. How do you balance that when the average office visit for Medicare has gone from, $250 for an office visit to down to $113 now? In some states, it's under $100 for an office visit for an E&M. Doctors don't have time to do that. It's less and less people are even getting into the profession of being a doctor because of that. So.
Yeah, and please, that was not an indictment on the physicians. I know they're doing everything they can, but
100%, and that's when we say that. You go on our website and you'll see we believe doctors want to do the right things, 100%. And our heart goes out to the doctors that we sit and talk with, because you can just see it on their face. They're going, help me. And I'm going, I can help you. I can show you how to do it. Technology is going to help with some of this. There's some things in place right now that we have with a company called Clarity Health that we just merged with that's going to make this process a little bit easier as doctors start to adopt technology. But we've got to get reimbursement to a place where physicians can make a decent living again so they can spend more than 5 minutes with a patient.
Dr. Spencer, you talked about prevention programs. Let's focus on that. What kind of programs do you espouse?
There aren't any particular ones that I do. I think there's always kind of the joke of, oh, well, what about the Just Say No and the DARE programs in school? And people say, oh, those didn't work. Well, actually, that's not true. We had the lowest drug use rates when we had those programs in place. Unfortunately, they've been completely stripped. I don't necessarily espouse to one in particular. Again, I go back to our messaging. And it isn't just, even when I go in and speak to students, I don't tell them what not to do. Because how many have kids? They don't want to be told what to do. And plus, you're stupid because you're an adult and you don't know what you're talking about and you have no idea what I'm experiencing. So kids don't like that. So Just Say No doesn't work on its own. You can't just say to your kids, don't use drugs. You have to tell them why. Kids want to know why. They want to know why not. So give them the information. Don't be afraid to have those conversations. And then again, for the school systems, it's tough. I hate to beat up on the education system, but it really does need to be within the school walls as well as in the home walls and in our communities, and kind of the messages that we're sending out there, even through our billboarding and TV, everything. I mean, it's everything we need to try to combat. But, you know, in the schools too, it's have your resource officers, you know, try to do some things. And I know Manatee County has been trying to do that over the last 2 years to bring in some sort of programming, you know, within the SROs. But again, they teach to test. They don't teach to connect anymore, which is unfortunate because their hands are kind of tied, much like the doctors. They have certain standards and benchmarks that they have to hit that they just don't have the time to implement these kind of programs in the classroom. But you know what? That's not an excuse, because there's free ways that you can do this within your school systems. You can have contests. You can create the environment that, you know, we're healthy, we eat fruits and vegetables, we get outside and we exercise. I mean, again, it's that whole mindset that needs to change. So I don't mean to ignore the question of which one do I espouse to, but again, it's anything that has to do with teaching our kids healthy living, healthy ways to deal with pain, to deal with loss, to deal with failure, and teaching them those ways. And again, I go back, it's up to all of us. And I kind of ignored your question about, you know, the kids and what do we do with those kids, because I'm guilty of it. I think we all need to come together as a community. I mean, they say it takes a village, and it's very cliche, but it's true. We should be helping those families. We should be helping those children. But none of us have time. I'm guilty of it. I barely can get off my couch half the time because I'd rather be watching television. So I'm guilty. I should be doing something to contribute to help those kids. I should be contributing an hour a week somewhere, you know, to make a difference in the life of that child that's been taken from home. We all need to come together. And again, I'm not up here saying I'm better than anyone, because I am. I'm guilty. I was on my couch all day today. I didn't do anything but watch television on my recordings. We need to kind of maybe step up. And we all can do this. And schools need to step up. I hate to say that, and I apologize if anyone's from the school system, but we need to step up, and there are ways to do it without even having to create a program or take and pay for or put money into or hours into in your school. So, sorry.
Jim, your thoughts?
Well, you know, I think Dr. Spencer's right. It's just not one program. And what kind of occurs to me is, you know, being in the legislature, often, you know, people come with lots of requests, and all of them sound really good, you know? It's like, well, if we do this, or if we did that, and not just with respect to drug treatments and the like, or education, but so many things. And, you know, there's a finite amount of dollars at the state level and at the local level from our tax money that we have to spend. And so we've got to figure out ways to, you know, very, very judiciously spend that money for the right things. And that's a challenge, you know, because there's several organizations in our state, the Department of Children and Family Services, Department of Juvenile Justice, just to name two. They're intimately involved in a lot of these issues that you're talking about, especially with children that are perhaps you know, taken from parents that, you know, aren't able to take care of their kids at that point in time. So how do we fund those, and what parts of those are good to fund? What programs of those are good to fund? And we've got to, you know, I think we've got to weed out some of those things from time to time in Tallahassee. As to, you know, how effective are they? Often, and I think this year we're seeing it in the legislature, you know, we're looking at everything we're spending, and is it producing what we expected it to for the dollars that we're spending on a variety of things across the board, not just with this issue. But so if we're spending money that we shouldn't be spending, or we don't need to spend any longer, where could we use that money, you know, better in a way that would be better for our communities and for our state? But government can't fix it. You know, government can be a resource but we're government. I mean, our money is what funds government. So we've got to figure out the best way to tackle it from a statewide down to cities and counties. But it really boils back to us, as you just said, Jessica, and each of us making a commitment. You know, I've seen program after program, and this is the younger people, and I get there's adults like us that are facing these issues and have these problems, but program after program locally where somebody mentors a kid for an hour a week, or somebody takes a young person under their wing to help them through a tough time, and it makes huge differences in those children's lives. So what are we doing is a great question. What am I doing? You know, I'm running back and forth to Tallahassee trying to represent the community, but when's the last time I mentored a kid? I hate to say it's been a while. So, you know, those are things that I think are critical for us to not lose focus on.
John, your thoughts?
I don't know that I have any.
Okay, I'm going to have a follow-up for Jim. Now, Jessica mentioned the teaching to the test, and that is the emphasis in our education system today. There's so many state mandates on that. Isn't it the legislature's responsibility to sort of back off on that so teachers can connect with their students better?
I am so glad you asked that question. Now, I'm also one that has not been on an education committee the time I've been in Tallahassee, and I just haven't been on an education committee, but very, very interested in education for our kids in our communities. And yes, we should look at that. And I believe and I think you all have written some of the articles about what we're doing and what we're looking at. And that is, are we over-testing kids? And a lot of us, myself included, think that we are. And you know, what should we really be doing day to day in the class, we being the teachers and the professionals, to educate and train our kids? And I'm excited about some of the momentum that seems to be starting to build to kind of strip back some of those things that just aren't productive, and they're just more preparing for the next test or the next, assessment, versus what's a civics class? What's phys ed? I mean, for crying out loud, a lot of us grew up with a phys ed in class, in school, and that was that I think was pretty useful. There's a couple of my colleagues this year promoting a bill to put phys ed back in schools, and some people kind of think, well, that's kind of silly, but think about what that does for a person's mind to get out and do something different than classwork and the like. So there's lots of things, recess, or probably a better choice of words, but so there's so many things that I think we should let the schools do. And the other thing, and I'll get off of it, we've been trying, and I'm encouraged, certainly there's a level of interaction at the state level, but the legislature I've been part of has been really trying hard to put those decisions back in the local schools' hands and let the school boards that are elected by, us and our community deal with these issues and decide what's best for kids in their classes and for the teachers in their classes. They can do it far better than we can at the state level. They're connecting with those families and those students every day. We ought to give them as much control and as much authority to manage their days and what they're doing as we can, I think.
Chris, my next question was also about education. I think we very effectively addressed that, so let's move up one. You want to take the next one?
This is from, we're going to get to the questions that our readers submitted. This is from Messina Cutting, and she asked,
That was the one we can move past that one. That was about education.
Oh, was it?
Yeah.
Oh, okay. Well, this one is from Misty Servia, who happens to be in the audience right now. A broad section of high school kids believe that marijuana is okay, since the recreational use is legal in several states and quickly expanding to others. Kids feel that a natural plant which has never resulted in an overdose and is not addictive can't possibly be harmful, and even beneficial if consumed as an edible. How do we as a community educate our kids and change that perception that weed is harmless? And is this the path to more addictive drugs like heroin? Dr. Spencer.
How did I know that question was going to come to me? I was like, can I please not talk about marijuana for once in the last 4 years? But no, I get it, and it's a really good question because it's an issue, and now we here in the state of Florida have unfortunately legalized marijuana, and it is sending a perception to our youth that marijuana is safe and marijuana is okay, but we have study after study after study that tells us it's not. And we need to also remember that the brain is made out of fat. It's all myelin. It's myelin sheath that covers all of your neurons and your transmitters. It's 3 pounds of fat, essentially. And marijuana stores in fatty tissue. Your brain is not fully developed until you're about 25. Why on earth are we going to allow this permissive culture of using a drug that sits in your fatty tissues when their brain isn't developed yet? It just doesn't make good sense. But that's a whole nother conversation too. The other issue that's out there is, if we legalize marijuana, we're going to solve our opioid crisis. That's not the case. Colorado is number 2 in the country for opioid addiction, and they've had legalized marijuana for recreational and medical purposes for years. We also know what the addiction rates are with marijuana. People who are addicted to marijuana are 3 times as likely to become addicted to heroin. This is one of the gateway drugs. Alcohol and tobacco are the other two. How do we do that? We go back to educating our kids that you don't need to smoke something, eat something, or drink something, or whatever to feel better. We need to teach them coping skills. That would be my answer to what kind of message can we start to send to the kids. And again, educate them. Don't just tell them to not smoke pot. Don't smoke weed, don't smoke the herb, don't touch it, it's bad for you. Tell them why. Explain to them how their brain works. Explain to them how their body works, how it is stored, what the interactions are with this substance, and everything else. Explain to them and give them the whys and the why nots and let them make that decision. They will make the right decision if you give them the tools and the education.
John, your thoughts?
I don't know that I have a real educated opinion as much as Dr. Spencer on marijuana. I don't personally smoke it, so I don't know much about it. I would tell you that if someone has addiction, it's obviously some of the studies, the way they're done. My personal feeling, and from the research that I've seen, typically people don't necessarily move straight in from marijuana into heroin if they don't already have the underlying disease of addiction. If they already have this disease or they already have a predisposition for addiction, it doesn't really matter what you throw out there. We see patients that when they get their urine drug screen back from the physician that are on 15 different drugs, and it just depends on what they can get their hands on that month. I don't know that there's a clear-cut pathway from one substance to another. The only clear-cut pathway that's really been that's been identified is opioid prescriptions and heroin, and that's very, very, very clear where that's coming from. So that's what I'd say to that.
Jim?
I would only add, and I think Dr. Spencer's been on the front line of this fight. We've talked and worked for a long time. Sadly, Florida, by a large percentage, voted in Amendment 2 last year, and it's the law, so it's part of our Constitution, so we've got to deal with it. Sadly, though, I believe we passed a bill 4 years ago, known as Charlotte's Web, that got at the medicinal marijuana component that we felt was the right thing for those that needed marijuana for medicine. I was against it to begin with. I was one that just doubted that that was the right thing to do, but I listened to testimony, I listened to experts, I listened to all of the people that were knowledgeable about debate and asked questions, answer on the issue, and I was convinced that was the right thing to do. And we didn't give that a chance to work, sadly, to see if it would work before the other side, if you will, mounted the multi-million-dollar campaign to pass what we have now. And it's going to change the complexion of Florida. It is what it is, and we've got to deal with it. And we're trying as best we can as a state legislature to put rules and guidelines around it that will hopefully minimize what we see as some of the impact, specifically in places like Colorado. But it's here, and it's unlikely to change. So we've got to figure out how do we manage it in our state level, in our communities, in a way that it hopefully will stay a medicinal type application, not full-blown recreational. But in essence, that's pretty much what we have, because now the ways to get it are not as complicated as you might think. And but we're going to try to deal with it from a state level to manage it and regulate it as best we can.
Okay. I'd like to recognize Carol Easton. Are you here, Carol? I'm a little blinded by these lights.
Just had to leave, actually.
Okay. Well, Carol had a very personal statement, so I had asked her. She's part of our team here at SCF. But what got to the heart with Carol was that Manatee County doesn't offer any free drug treatment programs. Sarasota does through a Viper program. And so her statement was, until there are some free treatment programs available, this problem will, of course, remain. Any comments on treatment, John?
Yeah, I feel very strongly about that. Again, there's no money in that right now, as far as it's not I hate saying follow the dollar, but again, people wonder why there isn't more companies like SureMed Compliance. We're a nonprofit. There isn't money in getting face-to-face with a physician. There's not a whole lot of money in treating the addicted unless through methadone clinics. I don't know if you guys are familiar with PAR and what goes on there, and I have mixed feelings about the effectiveness of methadone in treating that, and I think research will show that there's probably better ways to do so. But if we don't get at the underlying disease of addiction and treat those that have that problem, it doesn't really matter. Clinically administered heroin, which is what they do at PAR, it's given by a doctor. It's no different. Methadone, by the way, is used to treat pain. just like oxycodone, just like hydrocodone, just like those other drugs. You can go just show up at 6:30, 6 o'clock in the morning, and they're piled up all over the grass like it's a flea market. I mean, and they're in there, you know, and we know some of the complications with parents that are having to get methadone and all this, and it's just, I don't know that it's the answer. The answer is not, they're addicted, so let's give them something to keep them, so that it's clinically administered, because we're going to reduce the likelihood of an overdose that way. To me, it's let's get at the underlying cause here, which is we have to treat addiction. But again, there's insurances don't cover that. Buprenorphine's a very, very successful way of treating it as well, if it's done the right way. And yet the insurances don't cover buprenorphine. Right now, it's cash. It's all cash business. And so that's what we need to do. If they want to, right now, the money that comes in for the treatment of the addicted goes to basically clinically administered heroin. That's where the money's going. We need to have centers that are set up that look at this from all different. There needs to be a counseling involved in this. There needs to be buprenorphine possibly that gets covered by insurances. And these are simple things that when they've happened in other areas, it's made a huge impact in the addicted. So I don't know that it's necessarily even a kind of an unknown. We know that if we make buprenorphine more available and we counsel patients and give them resources to get help if they're addicted, most patients want help. Most people want help that are addicted, by the way. But as long as a doctor continues to prescribe, they continue to go in. They continue to go. And as long as they can get it on the street, they continue to go get it. The pressure needs to come from all around. If we had pockets of pressure where it forced people to stand up and say, okay, I need help, then people would do that. But we have a program right now that we do called the Care Continuity Program. We have care coordinators that call patients at home and administer assessments and talk to them about the drug use. And I would tell you that probably 80% of the patients that we talk to are addicts. They're not treating pain anymore. This isn't medical use of a drug anymore. They're addicted to it. And you hear them, and they want help. And they're in a haze, and they've been sitting on their couch for 10 years, and they're not a part of their kids' lives or their grandkids' lives, and they want help. And they cry on the phone with you, and they tell you, I wish I could get help. And there's nothing to do. And they go back in, the doctor writes them for their medicine. The other thing I would say is people always ask why Manatee County. I'm going to say something pretty controversial, so make sure the camera's on for this one. The number one prescriber of hydrocodone is in Manatee County. The number two prescriber of oxycodone is in Manatee County. So we've shut down pill mills, but we just opened up one huge center that actually took where all the pill people were going to get the pills, they go there now. So, you know, there's statistics to show that there's definitely some, I would say, coincidences, if you will, to why Manatee County is so big.
I think the thing, too, what's important I so appreciate your comments about methadone and certain companies and businesses in this area, because that is a huge problem. That's one way, and also I'm not sure it's being done in the best way and in the best interests of our patients and their clients. But what's interesting about the Viper program is that's not the Salvation Army. That's not one thing. Those are 6 different programs coming together. And it's not free. There's nothing free in this world. Someone is paying for that somewhere. So then the next question is when is the Viper program's funding going to run out? And then when is it our responsibility to be having car washes, fundraisers, whatever, to maybe, and there are free services here in Manatee County. There's Medicaid, but there's only certain numbers of beds that are available and spaces that are available at these treatment centers that maybe would be more well-rounded and not just going in and getting your dose and going home or going wherever you need to go. But how much money are we as taxpayers willing to pay to keep funding these free programs? Or when are we going to come together as communities, and again, going back down to prevention so that we don't have to keep throwing money at a problem instead of actually getting to the root cause of it. But when is the money for the Viper program going to run out? And then what? There's no sustainability to these, quote, free programs that we also need to look at. And maybe it is legislation, and I'm sorry, Representative Boyd. But maybe it is looking at legislation and looking at the budgeting. And maybe it's a national issue on how much money is going to come down into treatment. But again, we're looking at just that one piece. And it's not free. It costs all of us. It's taxpayers' dollars that go to those programs and those grants. And they run out. And then what do we do for those people that have heard about the Viper program and want to go, but can't because the doors are closed? What have we done as a community to provide sustainability to these programs so that doors are open for people, and maybe it is cross-county. You have to live in Sarasota County for 3 months, actually, for the Viper program. When are we going to stand up as a community and try to organize fundraisers and put money into our community and our help instead of saying, oh, well, I just want a free program? We've got to give back to everybody. We've got to give back to our communities, and we need to take our communities back. And if it is providing programming, great, but we need sustainability.
Since my name was mentioned, may I respond?
Absolutely.
Just kidding. That's a really good point and a good question. Where's the funding come from? And prior to legislative session every year, and then throughout the year when we're back home, I hear from dozens of agencies around our community that are all very good. And this is where it gets a little bit controversial. And I've had these conversations with them, but they overlap in so many ways, some of the same services. So they're all competing for similar dollars. And one gets it a little bit of that group, and the other gets it a little bit of the same group. And when, as a community and as a region, and I even suggest this with our friends from Sarasota, why don't we partner up as a region and decide what's important, who can do it best? And, we may not be able to have the same program, but I'll do what I do better, you do what you do better, and then those dollars are a little freer to go to the programs that can really get at whatever that particular service is, versus X organization doing 25% of it, B doing 25%, and so on. Let's focus our dollars and our tax dollars especially, because it isn't, as you said, it's not free. I mean, the money's coming out of our pockets that either go to local organizations or through our state tax dollar, or through the tax dollars to go to the state to distribute around. But why don't we look at more of collaboration on the issues that are important? Mental health is huge. A huge issue in our state, and I'm sad to sit here and tell you, as you know, we've been woefully underfunded as a state on the global issue of mental health service. We're trying to do more along those lines to help, but again, let's focus as a region on who can do particular services best, and let's not all compete for a portion of that service and those dollars.
Well, as a follow-up, we've started to hear the conversation for a statewide state of emergency or a national state of emergency to address this problem. What could that bring to bear if that were to take place?
Well, I would just start by, I know our Congressman Vern Buchanan and Senator Rubio have worked hard on some legislation and some funding from the federal level to come down to Florida, and I'm very grateful for that. They've identified and understand the problem, and they're working on it from the federal level. So that hopefully will help in terms of some dollars that will come to specific treatments and programs here in Florida. So that's one component. Obviously, we talked about what the state can do, and we're going to continue to try to do what we can there. But from the government's end and from your different levels of government, I think we need to partner with Manatee County and with Sarasota County, with the cities of our communities as well. But that's one way to hopefully get at it.
Thanks.
Our next question comes from Mary Ann Moyer of Bradenton. And she wonders if there have been any studies examining if the increasing use of Narcan is actually hurting the users and acting as an enabling agent. If a user knows that a family member or EMT will be there to rescue them when they overdose, where is their incentive to not overdose? Especially for the apparent statistic that there are users who have been treated by EMT as many as 2-3 times a day. What is the message we are sending them? And I'm going to start with you, Jessica, again.
I always get the hard, unpopular questions. It's a really good point. It's, again, a very unpopular point. But I think because he brought up earlier, nobody wants to be addicted. Nobody wants that you don't wake up in the morning and say, I think I'm going to become addicted to drugs today. That's just not how it happens. But unfortunately, it's a good point. There aren't any studies that I'm personally aware of, but I know every person in treatment that I talk to, they want to make sure they have it there so that they can use again, unfortunately. And, we've even seen it, in states that have the Narcan available to everyone. The overdose numbers don't go down. So is Narcan wonderful? Absolutely. Is it great and it's a wonderful, helpful tool? Absolutely. But it's not the only tool. It's not the only thing, and it's harm reduction. It's not prevention. We need to be looking at everything from prevention to harm reduction to education to treatment to legislation. Everything needs to come in. But unfortunately, it's a really good question, and it's an unpopular one that some people don't want to look at and don't want to acknowledge. But the whole thing is we are going to have to start asking ourselves some really hard questions. And we're going to have to start looking at our friends and neighbors honestly and truthfully. And that is the only way we're going to fix this problem, is if we all come together and we all get honest with one another and we look at what the real realities are, whether it be from training physicians, whether it be from training patients, educating patients on what they're taking. All pieces of this have to come together, and we have to be honest. And it's going to hurt, but we have to be honest. Otherwise, we're never going to get rid of this, and we really need to work together to do that.
John, your thoughts?
I think that question is looking at it as if patients, I keep calling them patients because that's what we deal with, but that users want to be addicted, or again, it's not a moral failing. I don't see this as a moral failing. I don't think that anybody wakes up and says, I got my Narcan, let's take it to the edge. Same question you can ask is, do cardiac stents let people eat more wedding cake? I mean, probably not. I don't think people go, I'm just going to have McDonald's 3 times a day because I know I can get a cardiac stent. I mean, I think people have real addiction issues, and they need help for the addiction again. It's the underlying disease of addiction. Again, I feel like I keep going back to that, but it's not a moral failing, and I don't believe that patients look at it and go, I got my Narcan, let's party. That's not the side. We deal with these patients every day. We talk to them on the phone. None of them act like that. None of them are like, let's go do this, let's go hard. This isn't like, some frat party in college. It's people that they are in the throes of addiction, and they hate it. They hate every day. They hate their lives. They hate taking it. They hate themselves. They hate the doctors that started them on it. They hate that, and they know that their time's coming. They know that it's only a matter of time before they push it too far, and they don't want to be there. So I would say that I don't think that Narcan is is it a bit of a safety net? I think it's a safety net for keeping people alive long enough to treat the addiction, but I don't think they see that as a safety net for them to push it even further.
Jim, any thoughts?
Well, these guys are more the experts on that subject. I know with Narcan particularly, the doses of the heroin and the fentanyl and the derivatives have gotten so strong that a normal dose of Narcan won't even help in many cases. So last year we were able to get Kaleo, one of the company that makes naloxone, the Narcan, donate, I think it was 400 units to Manatee County for the first responders, and trained them how to use it. And that was a great gift to our community, but they went through it like that. And in some cases it took dose after dose. And somebody mentioned earlier, in many cases, unfortunately, some of these addicts are being treated 2 or 3 times a day. I mean, they go to the emergency room, get stabilized, leave, and in lots of cases they're back the same afternoon. So look, if I have a family member or friend that is a potential user and probably could overdose, would I want Narcan? Absolutely, I'd want it around so my friend or loved one I could help save. But that's not saving all of them at this point, because the drugs have gotten so strong and so powerful that in many cases it's not enough. So
Right?
Okay. Anna Guzman, who is a second-year physical therapist assistant student here at SCF, states that research shows that physical therapy treatment can reduce or eliminate the need for opioids by improving physical function, increasing range of motion, and decreasing pain. The American Physical Therapy Association launched a national campaign, #ChoosePT, in an effort to educate consumers and prescribers about the opioid epidemic and urge them to choose physical therapy to manage pain without the risk of opioids. Do you consider physical therapy for your patients, and would you recommend it? John?
We discuss it all the time. When we do our workups with the patients and we uncover any kind of addiction issues or what we call red flags at all, and that patient becomes a high risk for misuse or diversion, we suggest, one of the suggestions that are made right away is physical therapy. Medicare now also covers acupuncture as well as deep tissue massage through physical therapy. We know both of those can be effective. The only problem is that once a month physical therapy is not going to get it done. So weekly physical therapies will definitely help with patients with pain. Again, there are some patients that have such debilitating issues that the only thing they can do is take low doses of opioids. So again, and I want to make this very clear as well, our job is not to tell a physician that no patient should be on an opioid. That is not what we think. We do know that at certain doses it becomes very, very problematic and risk factors go up. We know with concomitant use of like benzodiazepines that it's a death cocktail. I don't know if you guys know this, but over 90% of all overdoses with opioids involve not just opioids, but also benzodiazepines, which are Valium, Xanax, things like that. And a lot of times doctors are basically writing both of those together. We're writing both of those together because we know patients that take chronic opioid therapy have depression issues as well as anxiety issues. And so they would treat it with that as well. We know that's a death cocktail now. So physical therapy is a great way to do it. There needs to be more alternative treatments that are discovered. We need to have, and I think there's some good research being done right now in that area already, but we need to treat that disease state as almost like an orphan drug, kind of where we can get this thing passed through the FDA quickly and give some relief, because right now doctors don't have a whole lot in their toolkit to treat when a patient comes in with pain. So physical therapy is one thing we always do talk about, and we agree, and we recommend it to every physician that we encounter.
Okay, thanks. Any other thoughts on?
No, I think that's a great avenue. And again, it's something that should be discussed more. There's other alternatives. But unfortunately, we have created this society that the first thing when you walk into a doctor's office is give me that prescription. That it isn't the first thing that we should be looking for. We should be looking for alternatives and homeopathic ways. And, when you have a headache, use peppermint oil instead of taking an ibuprofen. It does wonders. It's amazing. So, no, I love this. I think we should be looking at that. Those are healthier ways, to heal our bodies instead of throwing a prescription at it. And it's not just for opioids. It's for almost anything. I mean, we run to the doctor's office when we get the sniffles. It's cold, people. Like, drink your orange juice and sleep, rest. Your body needs rest, but we run to the doctor's office for everything. So I hope that they get that message out. And I know LECOM, they've been doing work, trying to educate their students on not to run to the prescription pad first and talk about alternatives with their patients instead of just saying, well, no, here's a prescription that's going to fix that, and then unfortunately run into, the issue of overprescribing or overtaking our medications.
Our next question is from John Starost, and he asks, other countries, including Switzerland, Germany, Belgium, and Denmark, have adopted programs that are working fairly well. Holland, England, Spain, and Canada are trying the same programs. Have any of our panelists studied these programs, and your thoughts on those? Also, for people in constant pain, is marijuana an alternative solution? John?
I'm going to defer to Dr. Spencer on the marijuana thing just because I have very little experience with it and haven't really done any research on whether or not that's effective in pain or not. And to be honest, unless there's specifics about those programs in those countries, I don't know what they're...
Yeah, did he mention any specific programs? I mean, I don't think I've looked into anything, but he didn't list any programs on there?
No.
No, I have no idea.
I mean, I do know, in the United States, we consume 99% of the world's hydrocodone, and we make up about 4.6 of the world's population.
And we're one of the only countries that allow pharmaceutical companies to advertise on television.
Yeah, direct to consumer.
When can we federally get rid of
that?
that?
I worked for the evil empire for years, so the lobbying, but again, it's not readily available. Oxycodone, 80% of the oxycodone written is done in the United States, and again, we're 4.6% of the world's population. So these are not readily available things. I'm sure they're using other alternative treatments in those countries. But again, coming from a pharma background, I can tell you that pharma companies invest most of their time and money in the United States. It's the largest market by a landslide for all prescription drugs, not just pain pills. So.
Okay.
We have a little more than 10 minutes left.
Take a couple questions.
Yeah, we'll
from the
take a couple
audience.
questions from the audience,
Charles, can we get the handheld microphone?
since neither of us can move.
Yeah, we're taped down here. Do we have any questions from the audience? Yep.
Please, go ahead.
I apologize, I came in late, but isn't the theme of this meeting community interventions to help with the addiction crisis we've got going on? Yes?
Well, the theme was prevention and education and that sort of thing.
Okay, because I want to say I'm kind of shocked and stunned that I'm hearing information that is misinformation. You know, I really, in the light of an overdose epidemic in the state of Florida that's killing 10 people a day, and this is ground zero for overdoses, to talk about methadone not being a solution, I just think that's tragic. It's tragic. It has you have less risk of overdose being in a methadone program than you do walking out of an abstinence-based program. You know, and I think that maybe some education needs to be put out there that has actual data behind it. So, and I'm really scared listening to what I'm hearing here, because I don't hear any real education that's going to help in the crisis. I'm surrounded by mothers who have lost their children to overdose. So this is
And we're dear graduates. I still have this certificate.
So this is a big issue for us. And I'm the organizer of a community volunteer organization called Suncoast Harm Reduction Project. And we believe in community distribution of naloxone and things like that. Representative Boyd, I met with Abby in your office with the legislation for a community distribution, free, no cost to the state, to distribute naloxone to people on the streets that need it. And didn't go anywhere. And yet I hear there's legislation for a $500,000, $500,000, I guess, pilot for peer recovery services or peer recovery coaches. You know, that's stunning to me, because we have people dropping on the street all the time, you know. And here we are, volunteers in the community, wanting to reach out and help, and we feel like we're roadblocked at every turn. Now that's one issue. The other issue is, I think we need to educate in reality. You know, if you believe that addiction is a brain disease and that your brain structurally can change over years of use, then you know that for some entrenched users, methadone may be exactly the answer. And to make any kind of snarky comments about methadone or buprenorphine, because we're really talking about close to the same thing. Wow, that's sad. That's sad.
Can I?
And one last thing. We have a saying, not about us, without us. I've been in recovery 32 years, and I've been Narcaned. No one that's ever been Narcaned wants to ever be Narcaned again. I don't even like handling it when I'm doing a distribution. So I would just hope that if we're going to educate our youth and all the young people that I see out on the street, that we would give them some reality education and talk about things the way they really are.
Invite them to the conversation. Where are they? Where are the drug users?
Where are the drug users here? Anybody? Recovering people? Anybody?
Because you talk, we die, basically.
Right.
That's what's been going on here for 10 years. I mean,
And we've been
I think we did address that earlier, and I'm sorry that you actually missed that. We talked about a community coming together from every facet. It isn't just harm reduction, it isn't just education, it isn't just prevention, it isn't just legislation, it's everything. And bringing them and reducing, I actually mentioned, reducing that stigma. Allow these people and these family members and these are your neighbors to be able to have these open conversations. We all need to be able to come together from every facet. We did address that and we did talk about that earlier. I'm sorry that you missed that.
And that's good.
Was there do we have a question?
Yes, my question is this, then why am I sitting here listening to two educators be snarky about one of our most effective treatments for addressing opioid addiction?
I know for me, the snarkiness you're going to hear is that there's a particular program that doesn't actually even provide their data, but what we actually know is they are over-medicating, and the doses of methadone that they're actually providing are extremely high. And we also know that there's other options and other alternatives available. Methadone, great. It's a wonderful option, but not on its own. And I'm sorry, you may not have been here when John mentioned it. Again, it's coming together and providing counseling and all of those things.
As far as I know, I do know Operation PAR, and I do know they provide counseling.
Sure.
And it's required. So, I mean, that's kind of, like I said, misinformation. So my question is, how come we can't all work together and be on the same side? Because I got a feeling that I know things that maybe you don't know. You know, and you know some things I don't know.
Sure.
I didn't know about the Mylon, Jessica, or whatever you were talking about.
and the tea tree oil and sitting around
Right.
the table. Believe me and my daughter, we're like this, okay? Go for it. And I've had many conversations with my daughter
And it's not all about sitting around the table, eating fruits and vegetables, you know.
I don't think anyone said it was. I
You
think all
did.
of us up. No,
You
actually,
did.
I didn't.
And you're
We've all up
smirking,
in been
swinging
talking.
your legs around and smiling. My daughter's dead now, okay? This is not a laughing matter, and I am angry at your attitude, okay? I'm very upset.
I
at the way
apologize that
are.
you feel that I have an attitude,
I'm
and
very
I
upset.
absolutely, none of us up here said that it's
This
all about
gentleman
family.
here knows absolutely everything he said is fact. This gentleman right here.
I just want to say.
Thank you.
Yeah, let me just say this. I commend you for being in recovery for as long as you have, and my heart breaks for you with your daughter. I have very, very close personal attachment to this issue. It's the reason we started the company, because people in our family, immediate family, also have dealt with this issue. We haven't lost anybody, and we're grateful for that. But my heart goes out to you. I will tell you that, and I understand the sense of urgency that you guys have. We have it. The sense of urgency that's like, we need to do something now, and so I get that. And let me say, when it comes to methadone treatment, there's two groups of people. There are the people that are already in the throes of addiction, and we need to give them help, and methadone can be a way to do that. What I don't think needs to happen is that a lot of the funding, is where I was talking about, is going straight to methadone clinics. And while that's important to do that for those that are in recovery and those that are in the throes of addiction, a lot more money needs to go to prevent people from getting in that cycle. And that's kind of where my heart was in saying what I said about methadone, which it works. But I think treating addiction, it needs to be a comprehensive way of treating it, not just clinically administered methadone. I think for those people that absolutely need that to stay alive, absolutely give it to them. But then let's couple it with some counseling, real counseling. Let's couple it with.
Quite different from what you said earlier, which is like they line up for their liquid heroin or whatever they do.
Well, and again, I'm only speaking to the magnitude of the problem. That is not judgmental of people who are doing it. Believe me, I'm very compassionate. No, just the magnitude of the issue, and that is that a lot of the funding dollars are going to help people once they're already hooked, and at that point.
You know, we've been 3 years here in this area doing a harm reduction project. We were instrumental in passing the original naloxone bill. Oh, sorry. I'm so loud, I probably didn't need it. We were instrumental in, we instigated the original naloxone bill for third-party prescribing, the 2015 bill, and the pharmacy access bill the following year. And every year we've been going to the legislature trying to get little bits of harm reduction into the mix, because we found, and the data is there, that this saves people. You know, something like 26,000 people have been saved through community distribution programs of naloxone. So that's a big issue for us. But other harm reduction issues, like medication-assisted treatment, whether it's Suboxone or methadone, it's odd to me always that the state will fund Vivitrol. You know, they have no problem with that.
We're all first. I believe in Suboxone treatment. I believe if you can.
Well, everybody likes Suboxone because it's nice and clean, and you don't have to go to the clinic. Yeah, I get it.
Well, no, just from a biological standpoint,
It's a partial agonist. It's not the same thing for a lot of people. I'm an addiction specialist, and I've worked in a treatment for more than 2 decades, so I understand the difference between the two drugs. But what I'm saying is that when we're talking about an epidemic, this woman here lost her son, this woman lost her daughter, I lost my sister and my mother both to overdose. We have so much death and damage going on. When we talk about harm reduction, I think we really need to keep an open mind, you know, to the whole thing and not be snarky. I'm sorry, I feel like I'm beating up on you guys, and I don't mean to. I mean to insert myself into the conversation, you know, and that's part of my question. It's like, we never get asked any of this stuff. And we've been out on the street for 3 years and in the newspapers and holding naloxone trainings. We have a medical director that helps us, you know, and it's like people all over the country know who Suncoast Harm Reduction Project is, but Manatee County doesn't. You know, I don't get that. Like, so, I mean, how come all our tools aren't on the table in this crisis? And I would have loved if your office would have taken my bill.
Well, let me.
I was so disappointed.
Let me just speak, because I know they probably have
Yeah,
other
we're
questions. I
running
don't want
out
to
of
belabor
time.
it. But no, we listened to you. I know you were there. We know we talked. Your conversation is entered into the mix. Unfortunately, there's 160 of us in Tallahassee, and with respect to the $500,000, that's not a done deal. That's one member presented a concept that they were trying to get funding for. That doesn't mean that's going to happen, but no. But I hear you, and listen, what you tell us, what you give us, and what you share with us is important. And that's entered into the conversation in Tallahassee from a variety of levels. And I appreciate you being here, and I can't imagine what you all have lived through. And as John said, our heart breaks for that. But we're your friends. We're trying together to do what's right for our community. This lady right here is a tireless advocate for what's right. And we don't have it all figured out by any stretch of the imagination. We don't have all the answers. And together, I think we can collaborate and try to do what's right. Unfortunately, we can't just do everything that is asked of us right away, but certainly we're listening to you.
Well,
We're
we just
listening.
want to be at the table, you know, and I think drug users should be at the table, really, not about us, without us. You know, they have the best information. They know what's going on.
Well, I can, from a SureMed compliance standpoint, I would love to exchange information before we leave.
And we are running out of time. We've got 5 minutes left, and we invite our panelists for any closing remarks they'd like to make. Jim, you first.
Well, thank you all for being here. Thank you for your input. Thank you for the questions now, and thank you for the questions that were asked earlier and sent into us. We really do care, and we really do want to make a difference. I mean, there's nothing that I've been involved in since I've been in the legislature that is more devastating on every level than this problem. And I can tell you my colleagues in Tallahassee are interested in trying to come up with solutions. If we don't fix this, what difference does it make if we fix a bunch of other things? So I'm committed to it. Welcome your comments, welcome your input. Thank you for being here, and thank you for taking time to listen to us, because I promise you, this group is trying to do everything we can, and there's a lot of good people in our community that are trying to do the same thing.
I would say the same thing. Just the mere fact that the room is almost filled is fantastic. And again, it goes back to we all need to come together as a community. We need to stop the personal attacks, and we need to come together, and we need to meet at the table, and we need to talk about all options and all avenues. It's not going to be just one piece that's going to help. We all need to come together, and we all need to be honest with one another and with each other and with our kids and with our community and with our educators and our school system and our law enforcement and our legislators, which again, thank you for being here, because you do take these messages back to Tallahassee. I know you do. So thank you for everyone that is committed to this. Thank you for your statements. I am committed to this. I have been for 20 years. This is my life. And I hope we can all fix this problem here in Manatee, but it's going to take all of us coming together. This isn't about personally attacking each other. This is about coming together as communities, as families, as neighbors, as friends, as parents, as sisters and brothers, and trying to put the best things out there, well-rounded, to help our communities and save our children and save our families.
John?
Yeah, I think they said it all. I would just say, just to follow up, that until addiction is treated like a normal disease, like every other disease that you have, we're never going to solve the problem, because addiction in itself is the gateway to other diseases. And if doctors aren't assessing for that disease first before they even make clinical decisions on what you should be taking, and if we can figure out who it is that actually has a predisposition for this, we're much more likely to get them the help they need before they're written for a drug that is so powerful that they're within 30 to 60 to 90 days, they have no control over it anymore. So, yeah, that's all I would say.
Okay. Well, thank you all for attending our community conversation tonight. Once again, thanks to Chris Willey and the Bradenton Herald and Charles Clapsaddle and his METV team. This broadcast should be up in a couple days on METV's YouTube channel. Of course, our panel, so much thanks to you, Representative Boyd, Dr. Spencer, John. Appreciate you being with us tonight. I hope we have given all of you something more to consider as how we could use education and treatment to deal with this terrible issue impacting so much of our community. Thanks for visiting our Bradenton campus, and have a good night. Thank you.